roundtable sessions at which representatives from 111 organisations gathered to provide their perspective on the impact of the pandemic on their sector. And we have conducted a systematic evidence review of the impact on mental health. Finally, we have the benefits of accounts given to our listening exercise, Every Story Matters. All this material will help me reach my conclusions and inform any recommendations I make. I am deeply grateful to all those who have contributed in any way. Although there are some positive stories to come out of the pandemic, they are far outweighed by the negative stories, some of which are captured in the impact film that we're about to watch. There may be those who find parts of the film distressing. If you are one of those and following online, may I suggest you pause the live stream and return after just over 24 minutes. If you're here at Dorland House and you wish to do so, please leave the hearing room in a moment. The inquiry's website provides links to organisations which may be able to help, and at the hearing centre we have the Hestia support team ready to assist. After the film has been played, we shall reassemble, and Ms Kate Blackwell-Casey, counsel to the inquiry, will begin her opening submissions. She will set the scene and provide some background and explain the issues we shall be examining in the module in more detail. After her, and probably tomorrow morning, Ms Shaheen Rahman Casey, also counsel to the inquiry, will provide a summary of the discussions at the 9 roundtables. I will now pause for anyone who wishes to leave the hearing room or press pause on their device to do so.
I work in emergency services field. I would go into work and then use it as a distraction to combat my negative feelings about myself. Essentially, I just thought if I ended it now, people won't care about me. Wanting to fight that negative feeling, and I thought I could do it alone, but essentially I didn't have that strength to. No one can know how you're feeling unless I talk about it. I did attempt to commit suicide. On that day, I got saved by one of my friends. My parents was called to the place where I was. Got a big hug from my parents, and my mum said to me, what you need to do is you need to go to work and tell them how you're feeling. And I'm always grateful for all the support services I had helping me and helping me become stronger again. Always look back as lockdown as a positive feeling in terms of mental strength. I'm essentially a lockdown runner, and then since then I've challenged myself to different heights, let's say. When I race now and do these challenges, I always think back about the time I went through in lockdown. If I can get through that, then I can get through anything.
It just stopped, like everything just stopped for us. It was just one by one, just things just kept getting postponed or cancelled, and there was a hope maybe that things would just kind of clear up and like kind of just be stagnant, and then we would just kind of move on. But more and more, it just didn't happen, as we all know. We were able to actually move locations again from London back to where my roots were, basically. I don't think could have ever happened had the pandemic ever hit. Those things reassess your relationship to work and to family and to all those things. And I'd lost my dad just prior to COVID as well, just a few months before. Being able to really take time actually considering things and actually our relationship to everything really, I think was the benefit I found in that time. It was quite amazing how people could adapt. Like that was in the work in our industry, how the want and the need to adapt and to formulate new ways of working. I don't think it's ever come back as the thirst for it isn't necessarily there like it was before, but I hope I'm wrong about that, and I hope it will get better.
All the gigging that I had been doing just stopped overnight. Didn't look like gigging was coming back anytime soon. I know people that went back to university and studied law and all sorts of different things and have completely dropped music entirely. And as time went on, obviously, we got to see a lot of these venues that had been around for a long time close because they weren't making any money. They couldn't bring people in. A lot of the gigs have just kind of dried up overnight, whereas we were getting, 60 gigs a year, we're now getting 15. Financial support and mental health support, definitely the mental health support stuff. I didn't really know of any at the time, other than just finding a counsellor online and speaking to them about it.
The pandemic made the community know us better and understand what our organization does. We have lots of people from the community who became volunteers with us to deliver food. In this charity, we don't have the authority to refer anyone. We encourage the client to go and see the GPs. We lost a couple of our clients because of their mental health. They started thinking about when they will see their families back home, or why it is taking so long for their case to be concluded so they can have refugee status and be able to live a normal life. To be waiting for a long time and you don't know when this will be concluded, this makes it worse. It is heartbreaking, to be honest, to see, and they are all young. For me, it's like my children or my young brother. And to see them lost or committing suicide because of that, it really makes it tough. What shall we do?
As being a supermarket worker, I was dubbed a key worker somehow. In the aisles, I can notice that my colleagues were distancing a lot more away from me, but would be bunched up closer together next to their Caucasian colleagues or people that didn't identify as Asian. And similarly, customers would also brace themselves a bit more and also wear masks around me a bit more if I was, let's say, stocking or reducing something in the aisles, which was a bit disheartening. It's disheartening not feeling like you're wanted or you want to be spoken to or that you're being pushed aside because of your complexion. These stigmas carried on and kept going for so long and still do. And if there was more signalling, more messaging around that, I think we would be in a better position, in a better loving position of one another, I'd say.
We knew that the country was kind of shutting down. All of the teaching went online, but within a few weeks, the school had opened up again. I'm clinically vulnerable. I refused point blank to come in, and eventually I got signed off with stress because of the impact of everything that was going on. One of the changes I had to make pretty quickly was I had to reduce my hours at work, just so that I wasn't in the classroom as often. So that meant taking a pay cut. With a lot of underlying conditions, we don't know that we've got them until it is at the extreme. So something like the pandemic made a lot of people realise that actually they had got all these things going on, and it wasn't until they got COVID that they came to light.
You know, your office is normally a safe place where you can come in and you can have your moan about the job you've been to, or you can discuss things. And that discussion aspect was taken away. So some of our coping strategies really were harmed in the makeup of the COVID situation itself. We were dealing with COVID incidents quite regularly, where we'd turn up and there'd be like a party ongoing, massive group of people in a house, and we'd have to turn up and turf them all out. And violent incidents where you deal with somebody and halfway through, you can see them physically sweating and coughing and sneezing, and they're saying, well, I've got COVID, and they're spitting on you. And then you've got to take that home to your young family. I remember going to a job up the road where a guy was wandering through a farmer's field, and when we traced him, he was clearly having a mental episode, and he just had enough of being in the house and wanted to get out. And you can sympathise with that, but then we're having to deal with him. You've got to persuade, advise and warn, and then you've got to start hitting them with arrests and taking them down, giving them tickets and, you know, things that I wholly didn't agree with. There's less resilience in the force. My guys really struggle dealing with things on a day-to-day basis because they've had that resilience taken out of them. I think they're tired and overwhelmed by things, and I don't think that the COVID pandemic assisted that.
Trying to explain how you're feeling and how you're suffering with your mental health in a language that isn't your first language is incredibly challenging. And I think certainly people reporting to us, they're not able to say exactly how they feel. We were all trying to work out what was happening. We were all figuring out as we were going along. We had clients that didn't pick up on all of the changes that were happening. So we did have clients that spoke no English at all that would call us and say, I've received a fine for being out in public when I shouldn't have been. but I didn't know what the rules were. It wasn't getting to me in my own language. It took a long time after even all the restrictions being lifted for people to get back into any semblance of a normal routine and want to get involved in activities. And certainly there's still a fear around that, I see.
I remember we had nurses registering to use Food Club. We had council workers who'd been made redundant. We had people who worked in hospitality, like you said, and supermarkets. People who would say, I can't believe, I've never been to a place like this before, I can't believe I have to do it. And a lot of the other services didn't know what to do with people. Remember one day the police dropped somebody off with us who they found walking up and down in a hospital gown. I think they discharged themselves and they brought them to us because they didn't know where else to take him. I think we managed to get him in emergency accommodation that evening, got him some clothes, but that really was, desperate times, that person. So we had more registrations than ever, and we just tried to help as much people in any way we could. And then we decided to look at potential partnerships. And before we knew it, we had all these agencies operating out of this area over 2 floors to provide almost like a wraparound support service for people. So it kind of changed the way that we looked at things a little bit. And to be honest, that's been so successful, we still do that now. I would say that was one of the good things that came out of COVID. Like, it allowed us to start again and build up the service based on what people needed. I think it really uncovered like the true inequalities in our city, in our region. And yeah, we're still feeling the effects of it now.
We were overwhelmed with people. They didn't know where to go. They didn't know who to phone. They were just turning up, seeing unprecedented levels of demand and anxiety from people, angry people and stressed people. There was a guy we saw him quite often. He became known as the screaming man. So we'd see the screaming man on the street, and he was walking around in circles screaming because all the mental health services had shut. So the mental health services were all online. Homeless Project was online. Council offices were phone calls and online. Citizens Advice was online. So the screaming man used to just literally walk around in circles screaming. We saw all kinds of people with mental health issues coming in, and we had very angry people just because the help wasn't there, and the support worker that they saw every week, who would see them every week, and it was central to keeping them going, they didn't see them anymore. So we're seeing a lot of people struggling along on a lot less services than we used to see. And I think that's the lasting impact to this.
When the pandemic was about to start, in January, I lost my daughter due to domestic violence, and we were grieving. My husband had cancer, and my husband passed away in June, on the 4th of June. So I was grieving on my own, not knowing what to do, who do I speak to? It was weird. I couldn't speak to people on the phone. I couldn't sort of make arrangements for anything. I don't know what happened to me. It was like I was completely gone. The fear of getting COVID was one. And there was no support from the family, because they couldn't come. I mean, I could speak to them on the phone, but that was not enough for me.
With regard to my auntie, towards the end when she caught COVID, she got very ill very quick. My dad had a phone call Christmas Eve morning, told her she had passed away. So it was quite tough to come to terms with that. And when my parents told me, it was very much of like, I can't process it. I can't seem to understand. What was so hard is to see the people that you love in the same position, because for a very long time I stayed angry, and to an extent I'm still angry now. It's very hard to get people to understand that it killed a lot of people, and it killed people like my auntie. I struggle to this day with going to university and studying, and I get by, but I can't help but think if things were different, maybe I would have been able to cope with things better.
My brother Coming up to his 70th birthday, I noticed things changing. So he was diagnosed with Alzheimer's dementia. He was in and out of hospital a lot. When he was in hospital, social services decided he couldn't go back home. So he went into a beautiful local care home. So he had a couple of different hospital admissions. And then they rang me and told me that he had tested positive for COVID.
My father, who had dementia, he had vascular dementia, he was 90 at the time, a very fit man. He had a fall. He was taken to the hospital and they repaired his hip and he was happy. We were told that somebody put a patient in a room of 5 men who had COVID. He caught COVID.
I lost my mum to hospital-acquired COVID in May 2020 during the first lockdown. My mum, she had Crohn's, and we got to the Easter holidays. My mother-in-law rang and she said, your mum's not very well. The locum went and got her into hospital immediately. Even though she was on immunosuppressant, she was moved between wards for the couple of weeks. In the end, she had to have her large intestine removed. But she developed a cough the day before she went for the operation. She was making a recovery and the results came back and she was positive. So she was immediately moved again to a red ward. And she said, that's me now and I'm going to die.
2020, March time, Mum wasn't feeling great. And then it was the 31st when my dad rang me. And then my dad said, your mum is just really ill. And I remember saying to my husband, I don't want Mum to go into hospital. I was so scared that she just wasn't going to come out. So I remember calling the ambulance, and my dad had also pretty much, he'd had COVID as well. So he was also in a bad way. He even says to me now, I really regret not going up to your mum and hugging her and putting my arms around her, because none of us thought we were, that we weren't going to see her again. And then she was wheeled off. And I just thought, gosh, she'll be back. And I was like, Dad, don't worry, she'll be back.
I spoke to my dad and he was a little bit funny on the phone. Said, is Mum all right? The ambulance crew were there. She was to be admitted to hospital with a separate issue. I begged with the paramedic on the phone to not take my mum to hospital because I knew how bad the situation was. So she went, and then the bombshell, if you like, was COVID. The last time I spoke to her, I saw her on the iPad. The kids were with me, wife was with me, and it wasn't looking good. And she passed away on the Friday morning.
I have a brother who's got Down syndrome, and we lost my mum on the 19th of April, 2020. My brother had been staying with her for her birthday, so they took him back to his supported accommodation on the Monday. And then by Monday evening, she was phoning saying, I'm really not feeling all that great, I'm just going to go to my bed. So I said, I really think you need to phone NHS 24 and get some advice. But she was really reluctant to, because she'd said, if I go into hospital, I might not come back out again. Sure enough, they'd said, we'd like you to come into the hospital. She'd texted me to say that she wasn't very well and the doctor was going to phone me. We couldn't do anything, really. We were just always waiting for the phone call to come through. And I just saw the hospital's phone number coming up on my phone and thought, this is not good. But the doctor just said her organs were starting to fail and she wasn't going to make it.
The consultant from the high dependency came and he goes, she's really struggling with a CPAP machine. I think she's going to die. I said, so I can't see it then? No. He said, well, we can set up a last call for you. 2 lovely nurses held the iPad for my mum as I said goodbye to her.
We were doing a lot of praying as well. I'm not a religious person, but we were doing everything that we could to help her, I suppose. Somewhere between 6 and 11 minutes past 10 on a Sunday morning on the 5th of April 2020, Mum died. We were just stunned. We were completely stunned. Losing somebody like that, it's just so lonely because you're robbed of so many things.
The hardest thing I have ever done is say goodbye on FaceTime. I wasn't with him. I couldn't hold his hand. He died alone.
all the kind of key relatives had had a chance to see her except for my brother. And because he was in supported accommodation, we weren't really able to go and see him. The grieving process for my brother has been pretty traumatic. It's taken him a long time to kind of come to terms with the fact that she's not going to appear. The funeral directors were able to tell us who would be allowed to come to the funeral. But the biggest challenge that we had was my brother, because he was in a supported accommodation that was run by the local authority. Trying to get permission for him to come to the funeral was really quite horrendous and added further trauma to the experience. But going to the funeral and not being able to give him a hug or do anything was horrendous. If he hadn't had somebody strong enough to advocate for him, he wouldn't have been allowed to go to my mum's funeral, which was not okay.
He was a very well-liked man. Lots of friends, big personality, 30 people at the funeral. Sat in separate places, so my sister was with her family in one section because they were in one bubble. I was by myself. I was sat by myself. The priests were amazing. The service was incredible, beautiful service. And we managed to get this on the internet, you know, whatever you call it, so the families could see it, you know.
We have got a very strong tradition of wakes and funerals here. We weren't allowed to put a suit on him. We had no wake. When it came to the funeral, there was about 8 people there. We had to stand well back. And even my sisters, no hugs, no handshakes. And we just went home. And it breaks my heart that we couldn't pay him the respect that he deserved, and that he probably felt we let him down.
You know, with Sikh custom as well, like, you know, with the whole cremation, you know, you have rituals, as many cultures do. You know, you bathe the body, you dress the body, you pick out an outfit, you do all of those things, and we couldn't do any of it. It was like she just disappeared. We, you know, got in touch with like a local funeral home that specialised in sort of Sikh funerals and things like Indian, like Punjabi and that kind of thing. And they were really amazing. And then, of course, the whole streaming side of things as well, the fact that you were able to watch a funeral online, like that was not really a thing. Knowing that people said, we watched it, they weren't there with us in the crematorium, they weren't there at the Gurdwara afterwards, but we know that they watched it and stuff, and that gave us a sense of support as well, which was really nice.
I can't believe a life ended like that. And it wasn't just her. Unfortunately, everybody has a similar story. So you almost become numb to it. And that's what I fear now.
And our grieving process was really affected by not being able to do any of your day-to-day things. But it was quite intense, and obviously having the kids at home all the time because they weren't at school meant that you were kind of having to do a lot of the processing of all of the grief and all the practical things that need to be done. And my husband was acknowledging that I was supporting everybody. I was trying to support my dad, I was supporting my brother, I had all of these other things to deal with, and he was supporting me massively. But he also thought I should try and speak to somebody. But I really didn't find that experience positive. It was over the phone. The person didn't seem to understand what was happening, and I'd spoken about, you know, some of my friends' reactions to it and them not really understanding. And I just remember him saying, oh, it sounds almost like you're judging your friends. I said, I'm not judging my friends, I'm just telling you this is what the experience has been, and the impact on me has therefore been that I have felt like I haven't got anybody really to speak to other than my husband.
It's a complete different kind of grief, and to be told you're not allowed to see that loved one, it's so difficult for you to comprehend that they're gone. And even though I think the best interest was there with support, it didn't do anything.
The consequences, the impact is still being felt today, right now. I suppose I just threw everything into work, getting back to normal, helping Dad. Just put everybody else really first, which is my main priority. But it came down and really hit me the last 18 months, 2 years. I didn't make a fuss of it at the time because you just accepted the fact that You know, you weren't allowed to go into hospital unless you were allowed to visit. But I wasn't going to see Mum. It was to go and say goodbye to Mum. And it was only by asking the question, were people allowed? No. But did people go? Yes, they did. So why was I prevented to say goodbye? Hindsight's a wonderful thing to criticise, but there are issues that I'll never be able to get over from that.
But it was unimaginable pain that we went through, unimaginable, and there's a lot of regret as well. You know, when people say, "Oh, I know what you mean. I know what it's like." You know, when I lost so and so, but they didn't lose their loved one during the pandemic, and you think, no, you don't. You have no idea what it's like when somebody just leaves. And not only do they not come back, but then that's actually the last time that you've seen them. You don't even get to identify them. It's like somebody's just gone missing. They've just gone missing. And to kind of have to just accept that and find a way to make peace with it.
Those who died, died. Those who are alive, I think are living in hell, some of them, you know. And tomorrow's always the first day of the rest of their life. Nothing else matters.
I worry that now that the society has moved on and it's almost as if I'm being judged for mentioning it. Move on. The society's moved on. The world's moved on. But we can't. I'm stuck.
Thank you. Ms. Blackwell.
My lady, it is fitting that these final hearings begin with such a moving compilation of individual voices speaking to the personal impact of COVID-19. The most stark and terrible effect of the pandemic is found in that shared tragedy, in the devastating loss of life which resulted. We underline the figures cited time and again by the inquiry. They do not lose their power for repetition. The number of deaths across the UK for which the virus was responsible, calculated by whether COVID-19 is mentioned on the death certificate, is now over 230,000. The figure may yet be higher still. As you remarked at the outset of this inquiry, my lady, before COVID-19, nothing on this scale of loss from disease had been seen in more than a century. Behind those figures are individuals who died prematurely, leaving friends and families who experienced an unexpected and heartbreaking loss in pandemic conditions. Within those numbers, there are, we know, multiple losses from the same families or the same close-knit communities. Mothers and fathers, children, grandparents, aunts and uncles, wives, husbands, treasured friends lost. Shared grief must stand as one of the key impacts of COVID-19, and it is a consequence of the pandemic which cannot and will not be diminished in its examination by this inquiry. You have, my lady, already recognised that there were failures both in the preparedness for this whole system crisis and in the response to it. You have found that harm resulted not only from the pandemic, but from the inadequate government response. You have recognised that the impact of the pandemic was unequal, that vulnerable groups who were particularly susceptible not only to the virus itself, but also to the decisions made by the UK government and devolved administrations to reduce transmission. Yet, in large part, due to a lack of pandemic planning, limited consideration had been given to the indirect consequences arising from the response to it. Decision makers had limited understanding of the need to plan to mitigate the worst impacts of, for example, a lockdown. and it does not appear as if any of the governments entered into a systematic consideration of how the decisions that they took to combat the virus would affect vulnerable sectors of the population. You have found that when it was important for there to be centralised oversight of the impact which the pandemic was having on society, there was none. It is in that recognition and against that background that the true value of this module lies. Over 9 modules, my lady, you have considered evidence on the challenges faced as the COVID-19 pandemic gripped the world. While this was a public health crisis, its scale meant that every area of our lives was impacted, from the decisions taken in the face of the immediate healthcare risk to lockdown, test and trace, and vaccination. The impact of those measures took its toll on daily life, on work and leisure, education, and on business and personal finances. Much of this has continued long after lockdown and the pandemic period ended. In each of the inquiry's earlier modules, you have considered where things went wrong. You have reflected carefully on steps that might be taken to better prepare for the next pandemic or whole system crisis. Where in your earlier conclusions you have identified acts and omissions in the pandemic period that may have left scars on society, this module looks at the shape and depth of those scars and how the wounds that made them impacted on our communities and on individual lives. Each of your public hearings has begun with the voices of those impacted. Throughout, you have recognised that the story of COVID-19 cannot be fully appreciated without an understanding of how the pandemic was experienced beyond the rooms where decisions were taken. In order to better plan to meet the direct and indirect impacts of the next pandemic or whole system crisis, we need to appreciate how COVID-19 and the response to it was experienced in the UK. In this module and during these hearings, we focus on what the inquiry has learned about that impact. Every community has its own narrative. Every family has its own loss, and every individual has their own experience of COVID-19, which remains with them. For every addition carefully painted on the COVID memorial wall, images which surround us here as we work in Dorland House, there is the story of life and of loss, which contributes to our understanding as to how the UK was impacted as a society. It would be an impossible task to tell and to honour every single story, but during these short hearings, we will explore powerful evidence, some of which may be difficult to hear, including evidence of severe mental ill health and self-harm, evidence of fear, pain and suffering, death and bereavement. In order to put the voices of those most impacted at the heart of this module, while respecting the proportionality of your investigation, my lady, your inquiry team will take a range of steps. First, we acknowledge the important evidence on impact which you have already heard in earlier modules. This is evidence which we know will have stayed with you and which is reflected in each of your published reports. I refer to some of this material in these opening remarks to avoid repetition later on. Second, we welcome the continued participation of core participants who represent some of those most impacted by the pandemic. Third, you will hear from a small group of bereaved individuals about their experiences. Fourth, you will benefit from a wide range of contributions through the inquiry's Every Story Matters listening exercise. In this module, there are 3 separate Every Story Matters records, focusing on mental health and well-being, on key workers, and on bereavement. These records draw on 55,362 separate accounts shared with the inquiry and also provided during listening events which have taken place across the UK. The Every Story Matters team travelled to 43 towns and cities in England, Scotland, Wales and Northern Ireland, where they listened to the stories of many, many individuals. I will endeavour, where appropriate, to introduce some of these stories in opening these hearings. Fifth, your consideration of the evidence will be informed by the product of 9 roundtable events convened by the inquiry, bringing together organisations and individuals close to or representing experiences important to this part of the inquiry's work. These conversations, as you know, have culminated in 9 separate reports concerning faith and cultural institutions, community-level sports and leisure, travel, hospitality and retail, business leaders, key workers, housing and homelessness, justice, domestic abuse, and finally, funerals, burials and bereavement support. Tomorrow, Ms Rahman, King's Counsel, will introduce details from these roundtable reports, headlining some of the issues to which we will return with individual witnesses and experts. I now ask your permission, my lady, to adduce into evidence the 3 Every Story Matters records and the 9 inquiry roundtable summary reports for Module 10 so that they may be published by the inquiry on its website and addressed with such witnesses as may assist your consideration of the evidence.
They may be published.
Thank you. Over the next 3 weeks, you will hear evidence of how the UK was impacted by COVID-19 and the measures taken in response. As you have already made clear in your opening remarks, this is not an opportunity to revisit earlier issues of decision-making or to raise new criticism. That task has already been achieved by this inquiry. However, the evidence in this module does not exist in a vacuum. In order to understand the impact which the pandemic had, you may have to consider context. This will not involve a critical analysis of specific policies or decisions beyond your earlier findings and conclusions. For example, while you will consider evidence on the experiences of those living in poverty at the time the pandemic struck, it is outside the scope of this inquiry to scrutinise the underlying drivers of poverty and policies on social welfare. Your team and all core participants acknowledge your earlier findings and conclusions and the earlier evidence heard by the inquiry, which has led to those being made. It will be for you, my lady, to consider what impact that decision-making had upon UK society. In order to assist you in this regard, we have drafted a factual chronology of key events during the pandemic, which has been provided to your core participants prior to these hearings beginning for their consideration and input. I turn now to give an overview of our approach before descending into the detail of the evidence. In the course of these hearings, we will call witnesses whose evidence covers the themes central to your investigation and in accordance with your terms of reference. First, we will examine the impact on the general population of the UK by asking how their mental health and well-being was affected during the pandemic. Module 8 has already considered the impact on the well-being and mental health of children and young people. In this module, the inquiry will focus both on the well-being of the adult population as a whole and also on the experience of those with pre-existing severe mental ill health. Many of the stories in the Every Story Matters mental health and well-being record may be familiar to listeners. They may reflect their own experience, that of their friends and family, or experiences within their own communities, which strike chords of recognition. It is the task of this module to bring together those stories and the learning from those experiences. The inquiry has commissioned a systematic evidence review, which I will refer to as the evidence review, considering the impact of the COVID-19 pandemic on the mental health and well-being of the UK adult population, completed by the Centre for Strategy and Evaluation Services in 2025. It considered over 5,700 sources of evidence on the well-being and mental health of the adult UK population during the pandemic period and examined a final list of 98 studies before reaching its conclusions. As explained in the evidence review, we can view mental health as a continuum, with severe mental health conditions at one end and positive well-being at the other. Mental health is a dynamic state. People can experience symptoms of psychological distress without having a diagnosed condition or disorder. Similarly, people with severe mental ill health may experience periods of well-being. For the purposes of this module, we take well-being to refer to the positive state of feeling good and functioning well. The evidence review is careful to acknowledge where there may be gaps or weaknesses in the available data, but it provides a considered basis on which to explore our understanding of the impact of the pandemic on well-being and mental health across the UK. Second, we will hear from a range of experts instructed to assist your investigation of impact. You have heard from some of these expert witnesses in earlier modules. We will endeavour, as in other modules, not to repeat work you have done before. We will seek to draw on their cumulative expertise to explore shared themes and lessons to be learned. Third, we will explore community impacts, predominantly at a grassroots level, and the impact on key workers who met the challenge of keeping the country operational during the pandemic. You will hear evidence from the Local Government Association and their equivalents in Wales, Scotland and Northern Ireland in week 2. This evidence will focus on the impact of the pandemic at a community level and will not revisit decision-making either on a local or a national level. Fourth, we will look at the experiences which made some individuals and groups particularly vulnerable to adverse impacts during the pandemic and of measures taken in response. You have recognised in each of your earlier module reports that the impact of the pandemic was not felt equally. We will seek to build on the understanding of how this unequal impact was experienced, including by some groups you have recognised were hit particularly hard. Unequal impact is an issue which runs throughout all of your investigations in this module. Fifth, we will consider bereavement. The experience of loss of life during the pandemic period must be understood both as a national crisis and as personal tragedy on a national scale. Bereavement during the pandemic carried with it a level of additional impact. So many events of the pandemic and decisions taken in response were about life, risk to life, and managing loss. In this module, you will consider particular experiences of bereavement during the pandemic period. Finally, and throughout, your investigation in this module must necessarily be forward-looking. We will explore how our understanding of the pandemic of COVID-19 might inform the actions taken in preparation for and in response to the next pandemic or whole system civil emergency which the UK may face. In Module 2, you identified a series of lessons for decision makers in the future. In doing so, you have recognised that there are inevitable trade-offs between competing interests in an emergency, and that those responsible face intensely difficult decisions which may be assisted by a framework that considers social and economic consequences in the short, medium, and long term. We will explore the extent to which evidence about the impact of this pandemic can be used to inform the response to civil emergencies in the future. Now we will consider each of those headlines in turn. My lady, the first of which is mental health and well-being in the UK. It may be obvious or predictable that any national crisis, let alone a global public health crisis, could impact negatively on well-being and mental health. On the 18th of March 2020, a week after the World Health Organization declared COVID-19 a pandemic, it issued its own guidance on mental health and psychosocial considerations. Social isolation, loneliness, and declining mental health were obvious and significant consequences of social distancing. The potential implications of lockdown for individual well-being and mental health were clear before the first national lockdown on the 23rd of March 2020. And by the 24th of June 2020, an internal presentation at the Department of Health and Social Care recorded that evidence and experience from previous crises suggests that the COVID-19 pandemic is likely to lead to an increase in mental ill health in the UK as a result of both the illness itself and the social, economic and psychological impacts of the measures being taken to protect people from the virus. The impacts are likely to exacerbate existing inequalities and be felt more acutely by particular vulnerable groups, including young people, people who have been bereaved, and those recovering from severe symptoms of COVID-19, health and care workers, groups most affected by economic downturns, and groups who are already at risk of poorer mental health, including those with existing mental health conditions, Black, Asian and minority ethnic communities, and women. Mental health remains a devolved responsibility across areas of the UK. My lady, you will hear that the baseline for well-being and mental health in the UK before COVID-19 hit was, in fact, precarious. A substantial proportion of the population entered the pandemic with pre-existing mental health difficulties. Some people experienced improved well-being and mental health during the pandemic period, principally linked to increased time away from work, spent instead with family and on hobbies and self-care. As contributors to Every Story Matters have told the inquiry, the pandemic for some brought a moment of unexpected positivity and opportunities for time beyond their daily commitments to working life that they had never before enjoyed. The following are contributions that we have received. The lockdown restrictions were introduced, and as a result, I was able to work from home and spend a lot of very important time with my baby. Being furloughed and being able to try out new hobbies, crafts and DIY, spending time with my loved ones I lived with, were incredible for my mental health. I had work-life balance for the first time, and my physical and mental health and well-being were the best they had been in years. For some, the shift to life online provided new opportunities for growth and social contact that have continued beyond the pandemic. Professor Das Munshi, a professor of social and psychiatric epidemiology at King's College London, will explain that this positive experience extended to some people with pre-existing severe mental ill health. For some, the isolation reduced sensory and social overload and led to a reported sense of solidarity and a reduction in the social stress related to everyday life. However, overall, the COVID-19 pandemic caused a clear and evidenced deterioration in mental health and well-being across the general adult population. You will hear evidence later this week from Professor Sarah Stewart-Brown, Emeritus Professor of Public Health at the University of Warwick, who will speak to the work of the Evidence Review and its findings in this regard. The first national lockdown from the 23rd of March 2020 triggered a sharp deterioration of mental health and well-being across the general population, with clinically significant psychological distress rising by more than half compared to pre-pandemic levels. During the lockdown in spring 2020, people reported pronounced difficulties with concentration, sleep, and finding enjoyment in daily activities. The proportion of individuals unable to enjoy day-to-day activities nearly trebled, from around 17% in 2019 to 46% in April 2020, amid strict lockdown conditions. Overall, life satisfaction and happiness dropped, while feelings of loneliness rose. There were marked changes in the nation's psychological well-being, albeit that these impacts were uneven and experienced more significantly by some groups. Young adults, women, carers and people impacted by existing inequalities, including those with pre-existing mental health conditions or other disabilities, those in financial hardship, and individuals from ethnic minority groups experienced particular challenges. As one Scottish contributor to Every Story Matters told us, "When the country locked down, my mental health spiralled. At first, I was diagnosed with general anxiety disorder and depression. Then, the longer the restrictions were in place, it progressed to clinical depression and agoraphobia." Those who were clinically vulnerable and clinically extremely vulnerable and advised to shield, prolonged and repeated restrictions were associated with worsened mental health outcomes. We will turn to look at some of their particular difficulties experienced throughout the pandemic when we come to address the most vulnerable in society later in this opening. To assist your understanding of this topic, you will hear evidence from Professor Claire Herrick, Professor of Geography and Global Health at King's College London, and Professor Azim Majid, Professor of Primary Care and Public Health at Imperial College London later this week, and from Lara Wong on behalf of clinically vulnerable families, from whom you have already heard in previous modules, next week. Almost 40% of people experienced high or repeatedly elevated levels of psychological distress across multiple lockdowns. This consolidates the earlier evidence heard by the inquiry that 1 in 5 adults reported experiencing depression between June 2020 and early 2021, double the number before the pandemic. While increased psychological distress ranged from elevated levels of anxiety or reduced well-being for some, there was evidence of people developing new mental health conditions as a result of their experience in the pandemic. As one contributor to Every Story Matters explained at a listening event in Belfast, "Off the back of COVID, I have developed really bad obsessive-compulsive disorder. I still have it really bad. If someone said to me they had a sore throat, I would shut down and tell them to leave. I don't want to say it's post-traumatic stress disorder, but in a way, it feels like it." Feelings of isolation and loneliness directly contributed to the decline in mental health and well-being experienced as people were isolated from their families, friends, and wider communities. A Welsh contributor to Every Story Matters said, "The uncertainty, the loss of freedom, the inability to mix and socialise, the negative, fearful atmosphere, the separation from loved ones, the general anxiety caused by the situation and uncertainty. I had never felt suicidal before the pandemic, but reached a desperate state and had suicidal thoughts as a result of the restrictions, not the pandemic. Fear and uncertainty, particularly in the early stages of the pandemic, played a consistent role. Contributors told Every Story Matters, "I was worried about germs from parcels or letters or shopping delivered. Nothing felt safe. It began to affect my mental health, massive anxiety and inability to cope with stress. I developed agoraphobia, which affected my daily life. The daily briefing on TV during COVID caused me severe anxiety, particularly the death statistics. I was too terrified not to watch it in case it contained vital information. But every day I got more anxious. I was utterly isolated, and it gave me insomnia and nightmares when I could sleep." Some people reported finding positive ways to cope helped manage their anxiety and worry. Exercise, including walking, meditation, and learning new skills were ways that people found to cope. However, as in life beyond the pandemic, experiences varied. Many reported being denied access to their ordinary coping mechanisms, their activities which supported positive well-being, and some reported turning to reliance on drugs and alcohol. One contributor to Every Story Matters said, "Prior to COVID, I'd only been a social drinker and was able to control my drinking. In the initial lockdown, starting in March 2020, there was nothing to do. I started drinking it as it was the only thing that gave me something to look forward to." Loneliness and isolation from networks of support is prominent in the risk factors addressed in the evidence. For example, one contributor to Every Story Matters from England said, "When COVID hit, I had just been recently widowed and also lost both my parents very shortly after my husband. I was therefore incredibly isolated. All I could hear around me was my neighbours in their gardens and their families, laughing, eating together and chatting, and this simply increased my feeling of loneliness." You will hear from Professor Das Munchi that the impact of social isolation due to lockdown or other measures in response may have led to a deterioration in mental health for people with pre-existing severe mental health. One contributor to Every Story Matters said, "Having no routine, no social interaction, no exercise classes, no distractions, my mental health issues got progressively worse. I struggled to adapt, felt isolated, and became angry. I had no control over my external environment and didn't have any coping skills to manage my emotions. I fell back into patterns of self-harm, developed an eating disorder, and started relying on alcohol to cope with the days." And another contributor from Scotland told the inquiry, "I've struggled with my mental health since I was 11, and lockdown only made it worse. My depression worsened because of a lack of social connection, and I wasn't really talking to my family. It all got really hard, and I was self-harming multiple times a day, every day." Inequities experienced by those who suffered from severe mental illness were generally perceived to have deepened during the pandemic. Professor Das Munchi will explain that people with severe mental illness were more likely to die from all causes during the pandemic, including COVID-19. Prior to the pandemic, heightened risks of mortality for people with severe mental illness was already a well-known concern. Across most diagnoses, the risk of death from non-COVID causes was at least double the population average, and this continued through the pandemic period. However, excess deaths from COVID-19 were of particular concern, including for people with conditions such as schizophrenia, dementia, and eating disorders, who experienced high COVID-19 related deaths at a rate greater than within the general population. To the extent possible, we will explore with Professor Dasmunchi whether this was a predictable exacerbation of existing inequalities, attributable to the pandemic or to particular measures in response. During the first wave of the pandemic, there was a decrease in psychiatric presentations to emergency departments, including fewer acute mental health presentations. Professor Osborne, a clinical professor of psychiatric epidemiology at University College London, has referred in his report to research from 3 teams and 2 centres in central London, showing a 22% reduction in psychiatric presentations during the first week of the pandemic and a 48% reduction in emergency department presentations in the month following the first lockdown. This aligned with the introduction of measures in response to the pandemic and public health messaging, encouraging people to stay away from emergency departments where possible. Professor Dasmunchi also refers to important changes to service use during the pandemic, which may indicate some changes to symptoms during this period. For example, a UK study of primary care contacts in the early part of the pandemic suggested large reductions in people seeking primary care for a range of conditions, including severe mental health conditions. Professor Osborne notes that reduced presentations to GP services were observed in the first wave of the pandemic, returning to pre-pandemic expected levels by September 2020. There was a decrease in prescriptions for medications for mental health conditions in the first wave of the pandemic, but these levels returned to pre-pandemic levels after the first wave, March to August 2020. While there were fewer referrals in the initial lockdown period, this rebounded to some extent after the lockdown period. Moreover, the reduction was not felt in crisis team referrals or the rates of police using powers of detention under the Mental Health Act 1983, suggesting that urgent mental health needs continued through the early wave of the pandemic. When people did present to services, they may have presented with more acute symptoms. One contributor told Every Story Matters, "I came close to ending my life. I was admitted to hospital following a suicide attempt. I feel the admission could have been avoided if I'd been able just to sit down and talk with a skilled counsellor or therapist or in a group environment." There is some evidence that during the pandemic, a greater proportion of patients were detained under the Mental Health Act. For example, in Scotland, there was a 9.1% more detentions in 2020 to 2021 than in 2019 to 2020. Possible explanations to be explored include whether patients were responding to COVID-19 anxiety or public messaging to stay at home and were thus less likely to seek help. Some inpatient wards were closed or converted to provide COVID care. The risk of infection in inpatient care was considered high, and some patients were transferred home to reduce risk. Professor Osborne notes some reports of an increase in rapid discharges with the focus on freeing up beds. There was a reduction in patient admission during the first wave of the pandemic, although there may have been some degree of variation across the devolved nations and differences in local practices. Following lockdown, there were fewer discharges, but caseloads reportedly remained lower than pre-lockdown levels. For those in hospital, visits were inevitably impacted. There was less face-to-face contact and fewer therapeutic activities for patients. There was a lack of opportunity for patients to participate in activities outside of the ward. During the acute waves of the pandemic, there were reported staff shortages which impacted service delivery. Some staff were redeployed to support COVID-19 care. There were also long-term impacts for the NHS mental health workforce, with a high level of burnout and elevated rates of mental health problems for healthcare workers. A specialist mental health nurse told Every Story Matters, "We were burnt out physically and emotionally. Every COVID test before a shift was an anxiety moment because you knew if you tested positive, you'd be leaving your staff team dangerously short-staffed. You'd end up doing double shifts to cover staff sickness at detriment to your own mental health because you can't leave the patients in a dangerous situation." And another contributor said, "The staff I worked with gave their all on the wards to keep patients and each other safe. Some suffered or are suffering with PTSD, others with anxiety and depression or worse. Burnout is evident across this profession. I am, along with others, in counselling to deal with the trauma and after effects of working in these environments with the pressures described." There was reduced access to community care across the NHS and voluntary sector services for people with severe mental illness during the first phase of the pandemic. Many stopped all in-person contact. You will hear this had a particularly damaging impact for those with pre-existing severe mental illness. One contributor told Every Story Matters that they experienced a significant relapse in their bipolar disorder, having been unable to access their GP for face-to-face appointments. Some patients describe looking for alternative sources of support, including in online support groups, social media, self-management, and support from community or faith-based services. While the transition to life online and remote and online care during the pandemic was a positive step welcomed by some, this may have widened the inequity of impact for some particularly vulnerable groups. The rapid transition to remote consultation was seen as a success in the pandemic. However, it did not work for everyone and was reported to have generated difficulties for patients and staff alike. As one contributor to Every Story Matters said, "I have serious mental illness, schizoaffective disorder, and the lockdowns hit me hard. I was limited to phone contact for a 2-year period. In that time, I saw a mental health professional face-to-face only twice. I believe that period had a devastating impact on my mental wellness. I felt like no one cared about me. I felt utterly abandoned by everyone." As Professor Osborne explains in his report, remote technology was viewed positively, but there were major concerns that some groups of people with serious mental illness were unable to engage with remote interventions due to technological and physical barriers, as well as digital skills. This raised concerns about widening inequalities in care provision, including to older people. Staff were concerned that remote consultations diminished therapeutic relationships with patients and were not suitable for assessing complex mental health issues, including risk. Further, he acknowledges that difficult decisions were being taken in facing the risk of infection. Staff reported a tension between trying to provide responsive and high-quality care with the need for infection control. Service users strongly preferred face-to-face conversations, and some felt suspicious or anxious about remote services. Staff also indicated that service users expressed the inability to engage with remote mental health care due to lacking equipment and sufficient internet connection, lacking skills or confidence to engage with telehealth, or lacking suitably private environments for remote appointments. A psychotherapist told Every Story Matters, "In 2020, I was working in an NHS mental health service. When the first lockdown was announced, we were told to switch all our patient appointments to online or telephone overnight. For some patients, for example, those with poor hearing or people in domestic violence situations who didn't have a safe space to talk, this made the service inaccessible. The historic issue of higher levels of involuntary admissions of black and other ethnic minority groups has been recognised, in England at least, in the independent review of the Mental Health Act pre-pandemic. There is some evidence of increased healthcare needs during the pandemic, particularly for black and other ethnic minority groups. Professor Das Munshi notes one study which indicated that during the first lockdown in the UK, although overall admissions to mental health units dropped, a large proportion of admissions were compulsory detentions, which were mostly driven by higher compulsory admissions in black Caribbean mental health service users. In the second lockdown, compulsory detentions were elevated in the black Caribbean and black African groups compared to pre-pandemic periods. Higher levels of compulsory detentions in people with severe mental illness during the COVID-19 pandemic, against a backdrop of lower overall admissions, could suggest that a significant subset of the population experienced severe exacerbations of their mental health and were not able to access preventative timely interventions to prevent mental health relapses during the earlier stages of the pandemic. These findings may also suggest that pre-existing social, economic and health inequalities alongside structural racism were further magnified during the pandemic, which was associated with higher levels of compulsory admissions in black, Caribbean and black African people. Professor Osborne also notes that there was a higher incidence of first episode of psychosis in black and Asian groups prior to the pandemic, which may be explained by structural inequalities. However, the pandemic further exacerbated this already higher rate of incidence. We will return to the issue of unequal impact and vulnerability as an issue of priority focus for this module, as the impact on well-being and mental health was felt more keenly by some groups, not limited to black and ethnic minority people. The evidence review concludes, while the COVID-19 pandemic led to a widespread deterioration in mental health across the UK adult population, its impact was highly uneven. This unevenness served to magnify pre-existing social and economic inequalities, with certain groups experiencing significant greater challenges and slower recoveries. And my lady, when we come back after the break, I will continue to open these hearings relating to mental health and well-being.
Certainly, thank you very much. I shall return at midday.
All rise.
Jackie.
My lady, as part of the evidence on mental health and well-being, you will hear concern over data gaps in relation to ethnicity and other protected characteristics. And there may be inconsistency in the availability of data and analysis across the devolved areas of the UK. For example, Professor Das Munchi says her review of the evidence highlighted a dearth of data and high-quality research around impacts in people with severe mental illness, with ethnicity and other protected characteristics, and from devolved nations. The evidence review is also cautious in relation to the data available, for example, in relation to transgender people. Transgender and gender-diverse individuals are notably under-examined due to data limitations, for example, the lack of specific questions regarding gender identity in large population-based surveys, small population samples, and recording studies to binary gender. The paucity of data to allow for the effective understanding of impact is an issue already recognised by the inquiry and one to which we will return during these hearings. While periods of acute mental health crisis may overlap with periods of greatest restriction, there is evidence of adverse impacts on well-being and mental health continuing throughout the pandemic period. While there were signs of partial recovery in periods with fewer restrictions, a significant proportion of people were still struggling. The evidence review concludes, although overall mental health seemed to improve for a while, studies that followed people over time showed that almost 40% of people kept feeling high levels of stress or distress across several lockdowns. This means that the general improvements hid the fact that many people were still struggling. This enduring impact highlights that the pandemic was not merely a temporary disruption, rather it revealed and exacerbated systemic inequalities in mental health across the UK. Levels of general mental ill health across the UK population had not returned to pre-pandemic levels by the end of the pandemic period, nor by mid-2023. We will explore with witnesses the extent to which this may or may not be attributed to the pandemic or measures in response, or to other factors. The effects of long COVID have been identified as one ongoing challenge. The continuing impact of bereavement and loss remains another consistent feature in the evidence heard by the inquiry. It may be that the long-term and sustained impact of the pandemic on mental health and associated services are yet to be understood. We will consider what lessons may be learned for the future from the experience of individuals and the knowledge of the experts. I turn now to our second topic. Our second topic from our scope is community impact. Some degree of disruption to community life for the purposes of infection control in response to the pandemic was unavoidable. Once lockdown became inevitable, the degree of disruption was unprecedented, but not unpredictable. This module does not attempt to consider every aspect of how our communities, large and small, rural and urban, were impacted by the pandemic and the measures in response. However, this module considers some key impacts on community life, such as sport, leisure and cultural institutions. There is also evidence about the societal impact of the closure and reopening restrictions imposed on the hospitality, retail, travel and tourism industries and on places of worship. My lady, the burden of ensuring that community life could continue to the extent that it did rested in large part upon the key workers who were entrusted with keeping the country operational throughout the pandemic. You will hear evidence about their contributions and their sacrifices and the impact upon them of what they were required to do. You will also hear evidence about the impact of the pandemic on our communities caused by disruption to institutions such as the justice system. But first, cultural institutions, retail, hospitality, travel and tourism, community sport and leisure. The impact on each of these elements of our community life was devastating. The impact on the economic life of our communities, and in particular the economic viability of businesses most impacted by the pandemic and the measures in response, were touched upon in Module 9. We do not repeat that work, but we consider the societal impact of the pandemic across these sectors. And these are shared themes in the evidence, to which Ms Rahman, King's Counsel, will return tomorrow in introducing the roundtable reports. Lockdown in the early stages of the pandemic meant total lockdown for many. As restrictions eased, substantial change was often required to manage risk and to give customers, consumers, members or service users confidence to return. Behaviours changed and adapted with the evolution of the pandemic and the measures in response. The Business Leaders Roundtable discussed the shift to greater support for local community retail, with one attendee noting that there was some recognition about how important it was to have retail services close to where you live, and I think that changed consumer behaviours. However, another change observed was a shift away from the late-night economy to more socialising at home, with a reluctance on the part of younger people to return in the absence of habits formed during the pandemic period. A common theme throughout the evidence is that guidance and communications issued in response to the pandemic did not take a sufficiently sector-specific targeted approach. UK Hospitality told the Business Leaders Roundtable government guidance was general and not tailored to the specific needs of diverse hospitality subsectors, thus making it challenging to apply effectively across different types of businesses. The sector struggled with translating broad principles into practical, actionable steps for the wider variety of hospitality settings like restaurants, hotels, and children's play centres. Variations in guidance across the devolved nations caused confusion, particularly for businesses and organisations operating nationally or across borders. For example, Visit Britain raised the impact on UK coach operators of coach tours which operated across borders, and concerns that the confusion in guidance led to businesses not following appropriate rules. The timing of guidance and changes to guidance was cited as a particular issue. The Federation of Small Businesses said there was a tendency for the smaller iterations of guidance to be finished by end-of-day Friday, which made it difficult for head offices implementing knock-on processes. This meant staff would have to translate the guidance to make it easier to understand. Advantage Travel Partnership similarly emphasised that guidance often came last minute and via social media, without sufficient detail to allow for effective implementation. There was a view expressed that as a more collaborative relationship developed, industry and organisations improved guidance, leading to a greater level of clarity. An example given was work done by the British Retail Consortium and unions such as USDOR on workplace safety, such guidance then being adopted by government. A particular concern was expressed over the distinction between essential and non-essential business being inconsistent or without a clear rationale. Non-essential businesses that had to close at short notice found their trade, consumers and staff were immediately impacted and their long-term financial resilience was affected. As businesses, organisations and clubs shut down, this impacted significantly on staff and volunteers, some of whom did not return when venues reopened. Those attending the Business Leaders Roundtables spoke about the high levels of job insecurity across all business sectors. There was an appreciation that resource and talent had been lost. This was felt particularly keenly by cultural institutions and freelance workers. The Paul Hamlin Foundation told the Cultural Institutions Roundtable that the pandemic exposed weaknesses in the sector. The issue of burnouts, leaders leaving the industry, with everything shut down, and creative attempts to keep different types of work going, it really exposed the complex web of inequalities and pressure of our sector. Loss of talent extended into other sectors. Visit Britain told the Business Leaders Roundtable that whole bit about chefs going off and driving for Amazon, it did lead to a big drop-off in terms of talent we were able to hold on to, but also in terms of talent we were able to attract. Volunteers were also impacted, particularly in community sports and cultural institutions. Volunteering declined during the pandemic, and many were reluctant to return during the period of reopening while still considered to be at risk. As the pandemic restrictions continued, businesses were required to innovate. Businesses adapted by accelerating online capabilities, making use of outside spaces, and adapting to changes in consumer behaviour. For example, as restrictions eased, pubs and restaurants introduced the use of QR codes and apps to reduce direct contact. However, not all businesses and organisations were able to adapt, whether due to opportunity, capacity, or resources. Those businesses who couldn't adapt found it difficult to survive. The pandemic also led to innovation and opportunity in terms of how community sports and leisure was delivered. Clubs and classes moved online, providing free access to equipment for use at home and hosting social events outdoors. There was an increase in activities such as walking, running, cycling, and at-home fitness. Evidence suggests that net levels of physical activity fluctuated, decreasing but then rising again. A statement from Sport England explained to the inquiry that recovery to pre-pandemic levels of activity did not occur until mid-November 2021 into 2022. Again, there were disparities across demographic groups and inequalities were magnified. During the pandemic, cultural institutions also explored different kinds of innovation, including through outdoor events and the use of digital platforms. There is some evidence that innovation and outreach led to new contact with communities who had not before engaged with the arts. The Arts Council England told the Cultural Institutions Roundtable that many organisations connected with their local communities in a way they'd never done before. For many, the impact of closure was more straightforward than reopening. The British Retail Consortium noted the operational complexity involved, questioning the idea you could tell the country we're opening on Monday and expect staff to be in place, things to be sorted. Closing down was much easier than opening. As venues, services and facilities began to reopen, older people, disabled people and people who were clinically vulnerable remained concerned about the risk of contracting COVID-19. You will hear that concern over infection remains a substantial concern for those who live with clinical vulnerability. Hospitality Ulster told the Business Leaders Roundtable that this impacted on both businesses and consumers. As we reopened, the more vulnerable people stayed away. Younger people came back because I think they thought they were invincible. We still have a legacy where more vulnerable people still don't feel safe to come back. Turning to faith and places of worship. Many of the themes which we have just looked at are also reflected in the evidence on the impact resulting from the closure of places of worship. Ms Rahman, King's Counsel, will be drawing your attention to the descriptions given at the Faith Leaders and Places of Worship Roundtable of a profound sense of distress and loss. You will also hear from Daniel Singleton of Faith Action on how the closure of religious spaces had a significant impact on faith groups' worship practices. An inability to host religious festivals impacted religious practice. Some practices were less religiously meaningful when not carried out in person. The evidence on the impact of places of worship closing raises particular questions of cultural and religious sensitivity and equality. The loss of religious community spaces has been linked to a negative impact on the well-being of those who had been regular attendees, especially older people. There was resentment among some faith groups who believed that measures in response to the pandemic and associated guidance failed to consider different religions equally. Similarly, it was believed that a failure to prioritise faith over the reopening of non-essential retail, pubs and leisure facilities showed a disrespect for people of faith and the role of faith in daily life and resilience. Some faith leaders felt it was difficult to engage with the UK government over pandemic policies and guidance so that these could be tailored to what was appropriate for their religious practices, as far as possible within the confines of the scientific advice. Restrictions on in-person community services normally held in religious buildings led to some faith groups providing pandemic-specific services to vulnerable people. The pandemic also had a mixed impact on volunteering through faith groups, causing some to stop due to vulnerabilities, while prompting others to start volunteering. The closure of physical sites of worship led to an increase in online services and worship across religions. There is evidence suggesting an increase in attendance with this format, despite experiences of technological difficulties, the theological implications, inequality of digital access, and religious restrictions on the use of technology. For example, Daniel Singleton of Faith Action told us, our women's multi-faith group, particularly those who were Muslim, reported an increased attendance in women when services moved online because it made services more inclusive from a female perspective, increasing discretion and privacy. Buddhist groups noted that online services allowed them to connect with others that they couldn't normally interact with, as well as build an international community. For example, online services enabled over 1.5 million people to watch teaching from the Dalai Lama. You will hear from Faith Action that, at a community level, there was some constructive collaboration between community groups and local authorities. There were also positive contributions being made by non-profit organisations, including in the setting up and running of food banks, as reflected in the evidence of the Joseph Rowntree Foundation. We will explore evidence that innovation in the approach to maintaining community and community relationships, including through the expansion of digital technology, was positive, but excluded those without access to digital technologies or otherwise incapable of accessing digital life. My lady, I turn now to key workers, whose contribution and resilience is a significant chapter in the story of how COVID-19 impacted the UK as a nation. You will hear that the definitions of key, essential, and critical workers varied over the pandemic, and indeed that the approach to definitions and categorisation created some confusion and frustration. By any definition, the pandemic significantly impacted key workers across all sectors, not least due to the fear of contracting COVID-19 themselves or passing it on to others. Module 3 addressed the unique experience of healthcare workers, and Module 6, the experience of those working in the care home sector. However, key workers included many, from bus drivers to cleaning operatives, from those carrying out emergency services to teachers, from those working in factories to those stacking food on our shelves. At the Key Workers Roundtable, an initial sense of pride was described as people were recognised for their important roles in the early stages of lockdown, particularly in the retail, police and justice sectors. However, this early experience was not shared in all sectors and was short-lived in others. Key workers may not, for the most part, have experienced the same financial or job insecurities experienced by the general workforce during the pandemic, but they faced their own substantial risks and fears. One key services worker in England summed up their experience for Every Story Matters. Colleagues were literally terrified from the outset. We felt disposable, made to continue to bring in the revenue despite the known risks. Families of colleagues were anxious and worried about loved ones out there when you came home. What were you bringing in? Arguments and questions put enormous strain on families and relationships. The risk assessments implemented by the company were not adequate or reflected the work we did. Many felt let down, failed, and used. Key workers may have faced higher infection and mortality risks, but this varied by occupation. As you will hear, mortality data is held by profession, not specific key worker status. Transport and mobile machine drivers and operatives had the highest age-standardised rates of COVID-19 mortality, 78.7 COVID-19 deaths per 100,000 person years, amongst the occupational data collected by the Office of National Statistics. Yet teaching and educational professionals had the lowest age standardised rates of COVID-19 mortality, 16.9 COVID-19 deaths per 100,000 person years. Anxieties and tensions impacted negatively on the mental health of key workers. While the individual experience of key workers varied, there were shared fears and concerns. First, as to risks of infection, you will hear concerns over accessibility and effectiveness of PPE, and as to the methods of safe working. For example, that social distancing requirements did not take into account the close proximity in which firefighters would be required to work. Social distancing was impossible for nursery workers providing care for young children, prison officers who needed to restrain prisoners, and police officers visiting COVID-positive households. A prison officer told Every Story Matters, "I work in the prison service, so continued as I was a key worker. We felt like we were cannon fodder, as no one seemed to care about our welfare. No social distancing in work. We were scared of what could happen while trying to do our jobs." There were particular fears over physical working environments. Key workers in education discussed how air filtration systems were available but were not installed when needed. A police officer said, "It was never mentioned on television, police officers catching COVID and spreading it among colleagues and probably the public, due to a mostly windowless building." The Welsh Local Government Association have told us impacts on key workers were many and various. All workforce groups needed to conform with adjustments to a lesser or greater extent to well-established work practices. Many of these working methods were unfamiliar. At times, they led to some employees feeling uncomfortable and/or isolated. Second, as to confusion over guidance and working requirements, which extended to the definition of key workers and when they were considered to be acting in that role. Retail workers and council officers described how guidance was difficult to understand and often changing. Uncertainty over guidance on the part of key workers extended to those who were responsible for interpreting and implementing the guidance in the course of their own work. A priest in England told Every Story Matters, "Doing funerals was the hardest thing I did, explaining the rules and how I was going to interpret and enforce them, how our building would be prepared. Holding the anger of people was really difficult emotionally. Third, as to privacy and the boundaries between work and home. One teacher has told the inquiry, "The second lockdown, I spent all day at work teaching the ones in school, then setting all the work online and communicating with the homeschool group after work in my own time. I didn't have any energy left to homeschool my own children." Fourth, staff shortages and pressure to continue working rather than self-isolate or shield, including for clinically vulnerable key workers and key workers from clinically vulnerable families. A firefighter explained, "I was a frontline emergency services worker during the pandemic. I felt that little was done to protect us. Staff were regularly in close contact with staff from other areas as a way to cover shortfalls in staffing, and external contractors were brought onto our premises in large numbers throughout lockdown. Yes, shortfalls needed to be covered, but arrangements were given little thought, meaning that staff from a 70 by 30 mile geographical area regularly intermingled." A funeral director said, "The pressure was relentless. With the surge in deaths, my colleagues and I found ourselves working 70-plus hour weeks, often without a break. There was no respite, no downtime, just an endless stream of services to organise, people to prepare, and families to console." Finally, key workers expressed fears over infection and transmission of infection to family members. The fear of spreading COVID-19 to loved ones was very real for key workers, particularly those who were clinically vulnerable or who had vulnerable family members. Many described actions taken to protect family, and for some, those actions became habitual, with some developing anxiety or OCD-like symptoms. One cleaner told the Every Story Matters that her daughter was pregnant and her son had mosaic Down syndrome, rendering them both clinically vulnerable. She described her fears when her family caught COVID-19. Staff at her workplace had been reusing PPE. Tragically, her son died in hospital from COVID-19. She said, "My son died without any family member being with him. I will always carry the blame for causing his death, as I took COVID into our home. I reported incidents to my employer and to the workplace both before and after my son's death. Eventually, I contacted Health and Safety through the local council, who took matters very seriously and dealt with every one of my concerns and complaints, which were upheld and which, of course, led to my resignation at the workplace. My employer wanted to sack me." Many key workers said they did not feel appreciated for the personal sacrifices they made and the risks they took during the pandemic. One council worker told Every Story Matters, "Quite frankly, we were used as lambs to the slaughter, and the staff did their best to keep everything running while the management hid away and basically glory chased. As long as they could say they provided a service while they were safe at home, they were happy. We had to fight to get the full PPE we needed. We had to fight to get hand sanitizer." One teacher said, "On top of this stress, the media portrayed teachers as lazy. The reality was far from that. This led to huge amounts of stress. I did not sleep. I developed OCD around cleaning and hand washing and lived in absolute fear of contracting COVID. I would cry every day before having to go to work and spend my day in a high state of anxiety." Frontline workers said they faced anger and abuse, including some physical violence from members of the public when enforcing measures in response to the pandemic. This was not limited to police and emergency service workers. A supermarket worker in Wales told Every Story Matters, While in work, we would be subject to abuse daily. I've been spat on for refusing entry without a mask. I've been called racist for enforcing the same rules I enforced on everyone else. And I would have people every day tell me that COVID's not real, it's a joke. Key workers described long-lasting and detrimental impacts on their mental health. However, for some, continuing to work during the pandemic provided purpose and routine, helping to alleviate anxiety and stress. Some key workers said the pandemic had brought greater recognition to the work they did and gave them a sense of pride in the contribution they made to the pandemic response, including, in particular, key workers in the transport, food and retail sectors. A funeral director told Every Story Matters, "Yet through all this, we kept going. We showed up every day, often without the support or recognition we deserved, because it was our duty to help families in their darkest hours. We provided compassion, dignity and care when it was needed most. Working as a funeral director during the pandemic was a trial by fire, but it also reaffirmed the importance of our work and our commitment to serving others, even when no one was looking." You will hear that there is evidence of a particular prevalence of long COVID among key workers in the education sector. ONS data records that the number of education staff self-reporting long COVID symptoms rose by over 15% between December 2021 and January 2022, from 3.09% to 3.79% of the total workforce. One childcare worker told the inquiry, "I and other members of the team I work with are suffering with symptoms of long COVID. We have lost staff at a dramatic rate due to the lack of concern or respect by anyone in authority of the childcare sector." We will consider lessons that may be learned from these experiences. My lady, you will hear evidence from experts and from the TUC, 4 witnesses representing different areas of the UK workforce, here to recount their experiences of how the pandemic impacted upon them. You will be able to reflect on what they have to tell the inquiry, but cross-cutting themes already emerging include a lack of clarity in government messaging and the confusion which this caused. Turning to institutional impact and to users of the justice system. The impact of the pandemic on our communities includes that felt by many of our institutions. Taking one example, we consider the changes in the justice system as experienced by its users, from police officers to legal and administrative staff working at courts, including volunteers. There was a reported lack of clarity over key workers and others working within the system. Those who qualified and were not prevented from working for health reasons bore a heavier than usual burden. You will hear from Christopher Minnick, Chief Executive of the Legal Aid Practitioners Group, that the pandemic had a significant and adverse impact on the mental health and well-being of both those seeking legal advice and those providing legal advice. Throughout the pandemic, many practitioners were forced to spend more nights in police stations and cover more remand hearings in the day. Members were required to have meetings with vulnerable clients conducted over video, but reported significant variation in the reliability of technology. Members reported the additional strain of trying to assist distressed remand prisoners who were locked in their cells for 23.5 hours a day. As you are aware, my lady, there were widespread delays to legal proceedings caused by courts not sitting at all at the beginning of the pandemic and the resulting later shift to remote hearings. The pandemic made it harder for some victims of crime to access support from families, friends and organisations. Court delays during the pandemic may have undermined victims' confidence, including in whether they would achieve a timely outcome. For example, in the Domestic Abuse and Safeguarding Roundtable, the inquiry heard the pandemic restrictions led to challenges for the court system, and this was said to have affected domestic abuse cases. Courts were shut down with limited emergency processes in place. This created longer waiting times and unclear expectations on whether hearings would take place in person or online, and led to a reduced trust in the justice system. It caused some victims and survivors to question whether to continue with cases. The court delays also had a negative impact on the well-being and feelings of safety for victims and survivors. Representatives felt that these challenges highlighted the need for greater flexibility and innovation in the court system to better support victims and survivors of domestic abuse. Vulnerable people found it harder to access justice beyond the criminal courts, including in matters of family law and immigration hearings. These issues were addressed in the evidence of the Domestic Abuse Group and Migrant Rights Consortium, respectively. Effective justice became more difficult in the face of pandemic restrictions. The pandemic had an immediate and adverse impact on the justice system itself, those who worked within it, and on the ability of members of the public to obtain access to justice. Christopher Minnick has told the inquiry, the pandemic intensified existing strains on practitioners already struggling after more than a decade of fee cuts, falling prosecution rates, and a declining provider base, undermining public access to advice. But the most significant impact on those affected by the operation of the criminal justice system, defendants, victims, and witnesses, has been the large increase in court backlogs and delays in listing and hearing trials. The introduction of digital technology-based solutions led to positive outcomes for some in the justice system. Victim Support Scotland told the Justice System Roundtable about positive feedback from a pilot scheme for remote hearings in criminal cases that indicated that online hearings removed the fear of seeing the accused in person at court, which made the victim feel safer and better able to engage in the court process. The Justice System Roundtable recorded that participants considered that the shift towards remote court hearings had some positives, improving efficiency and enabling the courts to maintain legal processes in exceptional circumstances. However, the introduction of digital solutions left some users vulnerable and unsupported, with the same level of support not offered as in face-to-face hearings. The response in the courts was managed differently across the distinct and separate justice systems across the UK. Representatives from Scotland in the Justice System Roundtable described a reluctance in Scotland to transition to online hearings, which, it was said, contributed to court delays. However, this is an area where it appears that innovation driven by the pandemic, whilst initially viewed with hesitancy and caution, has resulted in lasting change beyond the pandemic for users of the justice system. The pandemic had a significant impact on the functioning of the coroner's service, which affected access to inquests, including how and when inquests were conducted. Unlike other areas and divisions of the UK justice systems, these impacts were felt by every person who lost a loved one during this period. You have received written evidence from the Chief Coroner of England and Wales, Her Honour Judge Alexia Duran, Mr Patrick Butler on behalf of the Presiding Coroner for Northern Ireland, and the Crown Agent and Chief Executive of the Crown Office and Procurator Fiscal Service, Mr. Stephen McGowan. Each of them have explained that access to coronial investigations, or in the case of Scotland, fatal accident inquiries, changed as a result of the pandemic. This included an explanation of how legislative changes were introduced by all governments in order to pause or relax certain procedural rules, thereby enabling the legal systems to continue to function. At the time that the pandemic struck, in England, COVID-19 was a notifiable disease under the Health Protection Notification Regulations 2010, but a death from COVID-19 did not require a referral to be made to a coroner. This meant that during the pandemic, such deaths were only referred if they fell within the notification obligations set out elsewhere in the relevant legislation, or if someone was concerned about the death and chose to contact a coroner. The Lord Advocate instructed the same approach to be taken in Scotland, consistent with that taken in relation to previous significant outbreaks of infectious disease, although this advice changed as the pandemic progressed in the light of significant public anxiety around deaths in care homes and of those who contracted COVID-19 at their place of work. In order to receive and investigate reports of deaths related to COVID-19, a deaths investigation team was set up, which then worked together with the Health and Safety Executive, local authorities, the Care Inspectorate and Police Scotland to ensure that appropriate investigations were undertaken. The purpose of these investigations was to ensure, so far as possible, that the full facts of the individual deaths were brought to light and to consider what, if any, further action was merited. Guidance from the Chief Coroner of England and Wales confirmed that, subject to the coroner being satisfied that there was no duty to investigate, deaths from COVID-19 were to be dealt with via the medical certificate of cause of death process, signed by a doctor and registered by the coroner. Furthermore, on the 25th of March 2020, the Coronavirus Act 2020 took effect, introducing a number of easements to the circumstances in which other deaths needed to be referred to the coroner. The Chief Coroner has told the inquiry, this helped the coroner service to function because the pandemic caused both a substantial increase in the numbers of deaths and a change in the way doctors cared for patients. Without the easements, many more natural deaths would have been referred to coroners because the legal requirements for those deaths to be certified by doctors and are registered without a coroner referral would not have been met. The pressure on the coroner service, which was already intense, would therefore have been even greater. However, it is possible that there were cases that ought to have been referred to a coroner but were not, because the scrutiny was less stringent during this period. One of the changes was to remove the mandatory requirement for a jury to sit on inquests into deaths which were suspected to have been caused by COVID-19. Jury cases tend to be more practically complex, cannot be conducted remotely, and at the time required extremely large court spaces to allow for the requirements of social distancing. Increasing the number of such cases within the coroner service would therefore have increased backlogs at a time when the service was already under immense pressure. As the pandemic progressed, regular guidance was issued by the Chief Coroner of England and Wales to coroners on topics such as adjourning complex inquests and using technology on topics, using technology to enable participation in those which were proceeding. However, not all coroner areas had sufficient video conferencing facilities. Many inquests had to be adjourned. In addition, although coroners, coroners' officers and staff were classed as key workers, those who were vulnerable or had vulnerable family members could not attend their workplaces. Their inability to work from home reduced the capacity of coroner areas to deal with death referrals and the early stages of death investigations, thereby increasing delays. Higher numbers of excess deaths put pressure on the death management system. In most parts of the country, mortuary storage capacity was anticipated to be seriously insufficient, affecting all deceased persons, not just those whose deaths were under the investigation of the coroner. And in some parts of the country, that risk materialised. As the chief coroner told the inquiry, how bereaved families experienced the investigation process will have been affected by the change in approach, although how they felt about it will have been varied. For example, some families do not want a post-mortem examination to be conducted for emotional and/or religious reasons, but others are desperate for there to be as extensive an investigation as possible. She added, coroners played an important role in identifying and managing the demands the pandemic placed on the wider death certification system. Coroners in each area worked as part of their local resilience forum, which brings together all relevant local individuals and organisations, including the police, ambulance service, GPs, hospitals, local authorities, etc., to manage the pressures, including setting up temporary mortuaries to mitigate the risk that existing provision would become overwhelmed, and working to ensure that bodies were released promptly. Where appropriate, a coroner has a duty to issue a prevention of future deaths report. During the pandemic, such reports were issued by coroners covering a variety of issues relating to COVID-19, for example, ambulance delays and the insufficiency of PPE. As was happening across the whole of the court estate, imaginative solutions were found in some areas to enable jury inquests to proceed. For example, Pitman's Parliament in Durham, a huge historic debating chamber and former headquarters of the Durham Miners Association, was adapted for use by coroners for inquests, as it was large enough to seat jurors and participants 2 metres apart. New arrangements like this improved access to inquests by enabling hearings to proceed that otherwise would have been adjourned. Similar arrangements were also made to increase capacity and alleviate the pressure on criminal and civil courts and tribunals with the setting up of Nightingale courts across England. However, as my lady will be well aware, the inevitable backlog caused by the pandemic remains at a high level. My lady, I'm about to move to deal with our third topic of vulnerability and impact. I noticed the time, and it's a little earlier than we would normally break for lunch, but
you know, I'm entirely in your hands. It's a lot of talking for you.
Yes.
So why don't we take a break now, and I shall return at 10 to 2.
Thank you.
All rise.